I mean, that's bad. But here's what's even more telling. If you look at her gliadin antibodies, and admittedly, this is just a marker that comes with this test, so I don't manipulate, I just let them run it. It's positive for it. This is by no means the best way to start looking for, sensitivity to gluten or gliadin or whichever fraction you're looking for on that. But it goes to further emphasize that she has an autoimmune antibody. She's reacting, her immune system's engaged, it's reacting. And your gliadin and gluten are going to be your more positive antibodies that are associated with the GAD antibody that we talked about very early on. So, think about that. Think about the fact that this lady has low vitamin D. Vitamin D is needed to regulate those T helper cells to control the immune response. I mean, this is a mess, right? So here's what I did with her. We've got the metabolic support formula, the omegas, the D, so we're pretty good on that now. Man, we got these plant-based antioxidants. I needed something with some horsepower behind it to try to really start to suppress that inflammatory response, and something that I could put in the background to help give me a little bit of modulation on her autoimmunity trend. There were red blood cell support, iron, B12, folate. She had implications for all of these. And of course, gastrointestinal repair nutrients. I mean, think about what her diet was. Her diet was carbohydrate, grain heavy, so she probably has some type of inflammatory response occurring in the gut. So we want to facilitate that. And then the paleo diet took all the grains out, and resistance training for short duration here. Because I needed something. I mean, this lady was really behind the 8 ball, right? I needed something to help me on the back end of this, get her and catch her up pretty fast. And resistance training is by far one of the best things that I could implement in there to help facilitate that. Last one out of my clinic here. This is an 11-year-old female, 4'11", 94, 20% body fat. Nothing really abnormal about that, right? Severe eczema, asthma. Previously treated with multiple courses of steroids. Okay, so now you're beginning to think about some impacts on steroid hormonal physiology here. We got the immune system engaged. Lethargic in the morning. That lethargic in the morning for someone this age may be the same as saying nausea in the morning. So don't rule that out, okay? Because we said nausea in the morning, thinking about that being related to hypoglycemia, okay? So don't rule that out with especially someone a little younger like this. No change in energy after eating. In her diet, look at what her diet mostly consisted of. Carbohydrates, more carbohydrates than ideal, and her breakfast in the morning, waffles with syrup, right? Here's the blood sugar roller coaster waiting to happen. But look at how many deficiencies she had at 11 years old, right? There's 15 different markers up there. And if we just kind of look at this, methylation impact here, overloading the liver with fructose, steroidal hormone, physiology here, gut dysfunction, vitamin D, and this one actually has a vitamin D deficiency driving it. So, I mean, a little bit of a mess too. You get the point out on all the printout, just looking at the various deficiencies there. These are just the graphs showing you where she fell on some of this stuff. But she actually did have a pretty significant vitamin D deficiency. But I put that in here to tell you that, look, when patients have vitamin D, whether you're finding it intracellular or in the serum, this calcium is going to be a good marker to look at too, because that really tells you what the functional utilization of that vitamin D is. And then she had a little bit of inflammation going there. And if you look at her insulin levels, again, she's 11 years old. She was actually a reasonably active kid too. And her insulin levels are at 8.1. Make a few dietary modifications in there, that changes. Homocysteine levels at a 7.7. I really try to get these patients down to under 7 on this, 7 or below. And you'll start to see that, because remember she had a B12 deficiency. You'll see that when the patients have B12 deficiencies, more times than not, their homocysteines are going to be above 7 on this. So there's definitely a correlation there. And for her, kind of the same type of presentation of the D, the omegas, the B12, and then you get into some different things here. You guys are probably looking at that thinking I do vitamin D, B12, omegas on everybody. Well, pretty much, yeah, right? And I mean, I don't do it just willy-nilly. I have justification for it, right? The paleo diet removed. And actually, this kid, after going on this, within her eczema, I wouldn't say it was severe. I would say it was moderate, though. She did have some pretty reasonable lesions. Within a month, you could see a pretty noticeable difference. I mean, what I hated about this, she was so self-conscious about it, right? I mean, and she was a pretty young girl, but she wanted to hide herself. And she would come in with her mom, and when they came in for their initial follow-up, after we had been doing this for a while, you could see a totally different demeanor in this kid. And I asked her mom, I was like, is she interacting better at school? Oh yeah, she's great. She's more social now. She's not so apprehensive about what people are going to think about her. I mean, that's the kind of stuff we do, and that's cool. And that's just from looking at these micronutrient profiles.
You didn't mention outcomes on that too.
So on the second case study, she didn't follow through. She didn't want to follow through. She didn't want to make the changes on the diet. Sometimes you win, sometimes you lose, right? On the initial study, I don't remember that one off the top of my head, so don't have a good outcome to tell you on that one. One last thing here I want to point out to you. This was actually looking at the British Medical Journal, or out of the British Medical Journal. I'm going to actually read this one to you because this one's pretty profound. A 5-year, 10-month-old boy was diagnosed with classic type 1 diabetes mellitus without celiac disease. He started on a gluten-free diet after 2 to 3 weeks without need of insulin treatment. At the initiation of a gluten-free diet, HbA1c was 7.8 and was stabilized at 5.8 to 6. So without insulin therapy. Okay? Fasting blood glucose was maintained at 4 to 5 millimoles per liter. And for us, thinking more milligrams per deciliter, that translates to 72 to 90. At 16 months after diagnosis of fasting blood glucose at 4.1, after 20 months, he is still without daily insulin therapy. So just changing the diet, just modifying those inflammatory responses took, you have to be kind of cautious about how you say these things sometimes, but the presentation of type 1 diabetes is no longer present in this particular report. Right? It's pretty significant. So here's the takeaways from hopefully the presentation for you today. You want to watch for nutrient patterns to detect early indications of dysglycemia. So in looking at these nutrient patterns, you've got the handout there. You don't have to have every single nutrient that's listed in those patterns for that pattern to exist. Just start thinking about from your history and from what you're seeing in the report, what's the likelihood that is the pattern for that patient, and if you replete those nutrients that are present in that pattern, that's specific. That's the biochemical need for that patient. Right? So you'll have better clinical outcomes with them. Watch nutrient patterns to determine secondary causes of dysglycemia. So that slide with everything around it. Look for subtle shifts in traditional glucose markers. Little shifts in that insulin, little shifts in that glucose. You'll start to see when you check the micronutrient test at the same time with that, those shifts on the micronutrient test aren't subtle. And it's only a matter of time before the subtle shifts in traditional markers become pretty significant shifts. Identifying nutrient patterns allows you to predict the patient's health. So there's very definitely a predictive nature about this. And don't forget about biochemical individuality. That's probably for me, one of the main reasons that I like using the micronutrient test is because it narrows down what is the need for that patient. It's testing their lymphocytes against their need. It's not putting them against a range. It's not testing them against a standardization within the population. It's that patient's cells and looking for that patient's need within those cells. Yeah, and my little tidbit, when in diet, use the paleo diet as your starting point, right? Do you guys have any questions?
How accurate is the vitamin K2 in there, in that test? There's liquid chromatography testing. Dr. Sugar's in the Netherlands. He's the vitamin K expert. He says there's no commercial, that's what he's working on, no commercial good way to check the vitamin K. So I'm just wondering how that compares to tests that are done in research facilities. I don't know how to trust it, in other words.
I don't know.
Okay.
I don't know the answer to your question.
Okay.
Yeah. I mean, I can tell you that that's not a nutrient deficiency that pops up a lot. I don't have enough lab background to be able to differentiate different methodologies for you. So, I'm sorry.
2 questions. How often are you repeating the test? And then with vitamin D, if you're seeing that it's not repleting with supplementation, do you just increase the dose, or are you looking at some type of other pancreatic enzymes that need to increase absorption? Any thoughts on that?
Okay, so to your first question, looking at the frequency of the test, my algorithm in my clinic is we do the initial test, at 6 months I'm going to repeat the test. At 6 months after that I'm going to repeat it again, and then thereafter it's annually as a just kind of a maintenance type for their health thing for them. The reason I use that 4 to 6 month time frame is because typically with the battery of tests that I use, that fits consistently. They all kind of fit consistently together at that time frame. But the other reason that I use, and I point this out I would bet you on 90% of my reported findings, I point this out to my patients, is that on the reports back from Spectracell, it says 4 to 6 months is needed for sufficient repletion within the lymphocytes. So I do that so it gives them an expectation of time, so they have in their mind how long is it we need to be working on what we're setting up at the time that we're doing the initial report of findings. For vitamin D, if I don't get the levels repleted, I most of the time my initial approach is to upregulate, or not upregulate, to up the dose on the dosing. So I'll probably start at, depending on what the presentation is, if I've got somebody who, you know, they're not heavy set individual, not overweight, obese, anything like that, I'll probably go to 15,000. If they are overweight, obese, I go to 20. And things you want to think about on the back end of that, you might want to look for vitamin D receptor gene variants. You might want to also consider all the other mechanisms for where vitamin D is utilized and think about, do you have something that's increasing the demand for vitamin D? Maybe specifically, as we've talked about today, thinking about the immune system response. And then the other thing I would think about there would be your production. Does the patient inherently have something that's limiting their production of vitamin D? And you can just kind of go back and go from your starting point of cholesterol, and just kind of work through the different organ systems to start with cholesterol, having it in adequate quantities, and then go from there to your liver, to your kidney, and just kind of work through that production pathway.
And look for malabsorption like celiac disease and gastric bypass, you know, look for malabsorption. I need to maybe do sublingual.
Right. Any other questions?
If people are taking calcium channel blocker medications, do you expect the calcium to show up low on the micronutrient test?
Not necessarily. It'll come back in insufficient levels. Yeah, it doesn't necessarily show up low. And normally with that, you know, if you do know that that's a medication that the patients are on, that may be another scenario where you might want to put a little bit of like a maintenance level, maybe even like 200-300 milligrams, something like that, where you know they're at increased risk for loss. But in general, I'm just kind of thinking back to my patient population, that's not one that I see when they're on that medication. I don't see that one come up deficient.
When people are critically low in their B12, do you find that giving sublingual B12 is good enough to replete them, or would you recommend injections at that time?
Okay, so here's how I do this. What I do is, if I see that the B12 is deficient, this is like an area in my practice that I'm trying to work through right now. So I'm gonna share my experience with this. What I'm gonna do. Okay, if you've got a deficiency on the micronutrient in B12, and let's just throw folate in there too, okay? Because they'll show up together a lot of times. And then as I looked at the MCV level on the CBC where it was above 92. If it's above 92, definitely I'm treating with B12 folate. I treat that for 4 to 6 months, and I retest it. And I start off with oral supplementation. I'm usually dosing in the neighborhood of about 4 milligrams on the B12. And I retest it 4 to 6 months. If the MCV level hasn't been corrected, then I start looking for pernicious anemia. So I start running the parietal cell and intrinsic factor antibodies. Once I've got that, if I, depending on, let's just say it's positive. If it's positive, then I start either doing injections, transdermal, or sublingual. A lot of times I will do transdermal or sublingual over injections, not because there's anything wrong with the injections, just patients don't like getting stuck. So that's the only reason. The injections work just fine. They work great. There's some patients I will tell, I'm sorry, you're going to have to get a little bee sting every day, but you got to do the injections for a period of time so I can really ramp these levels up for you and get you out of a pretty significant deficiency. So, and I have had one patient that we literally had to do 2 milligrams of injection every day for 30 days to yank him out of the hole.
Wow.
So, and that's one. I mean, that's the exception rather than the rule, but it is there. So.
Are these patients like anemic, or their MCV is the only marker that's?
The MCV in this particular gentleman's case, it was the MCV. That was what I wanted to tell you too. When you go back and recheck the micronutrient levels, a lot of times on the micronutrient test, a lot of times even if pernicious anemia is there, that B12 level will correct. I cannot figure out why it's doing that. If any of you have any input or insight on that, I would love to hear it, because just basic physiology, it doesn't make sense, but it sure does seem it corrects it. So, but it doesn't fix the MCV, and the homocysteine will still usually be a little bit above 7.2.
I had a fellow with this test done a year apart, and his MCV stayed at 103, but his B12 and folate were normal both times. So I was thinking I should do a methylmalonic acid to really verify if he's functionally sufficient.
I mean, it's definitely worth looking into. I mean, it's worth looking into is all I'm going to tell you on that, because it's the same, you know, what you're describing is exactly what I was referring to. So it's interesting. There's a gap in our knowledge there. So, for another night, I got to stay up researching
Isn't
something.
it just possible that if you're not anemic, it's a bell curve, your cells, you have macrocytosis, so you're not anemic. If you've got the B12 and folate corrected, maybe it's not a problem. Maybe it's just there's an outlier on the bell curve, and there's not. If the person feels fine,
Yeah.
and they have a persistently elevated MCV, I've certainly seen that. I've also seen somebody have a concomitant pernicious anemia and a microcytic anemia, so that their MCV was normal, but had markers for each, which was very interesting. So we were able to correct both, but we had to do what where you did the iron, folate, and the B12.
Yeah, and I mean, that's a very likely scenario. I know the ones that thinking about the ones I've seen more recently that fit that particular clinical picture, even when they're MCV, I'm trying to get it above 92, even when they were around 93, 93.5, they still didn't feel good. They still felt pretty fatigued.
I'm not an expert in this. I just watched the webinar that Spectracell has on the MTHR deficiencies and the methylcobalamin and the disruption of the endocrine pathways, and so there might be a reason why these things fit together, because they were talking about the MCV correcting with the methyl
So look at that.
variants. Yeah.
Thank you.
Any other questions? Well, like I said earlier, I really appreciate you taking time out of your schedule to come today. I know Spectracell and Lynn as well. I appreciate you being here. If you have any questions for me, don't hesitate to get in contact with me. Lynn has my contact information. I'll be happy to answer any questions, help you however I can. So, but again, thank you for coming out.
Thank you.
Yeah. Very good. Very good.
Actually, I'm not working anyway.
Yeah, I think everybody in the country should. It's so expensive.
I know.
Best deal there is.
It really is.
Or the white milk.
No, I may do it for both my kids. I was Oh, no. That's true. They're not compliant, they don't care.
How it affects their life.
Right. Right.
Is this good market?
Yeah.
hospital. She was assigned as a and
that goes also my son goes with all ADD is brain inflammation. He gets it almost like just like that. Make sure she doesn't have celiac.
I know.
One of them worked at an orthopedic clinic. She was 62. You know, she'd always complain of these aches and pains. I said, go and check and see if it's celiac. She had celiac, but she got her diet changed half of her things, but she was always listed as fibromyalgia.
Yeah, I see a lot of that.
Different things. I mean, scientists are trying to find a marker for it. And I tell the scientists, you're not going to find a marker. It's too many other things that
So you correct all this, I mean, hormones, adrenal, everything, and they don't have it anymore.
Yeah, they have other things too, but which test are you doing for celiac? 21
well, a lot of hospitals will have a celiac panel. They'll have the 3 antibodies. TTG is probably the most common. If you do for 3 labs, it's about 95% accurate. I mean, there's the stool testing too.
That's what we do.
Yeah.
And we have a new one that we've been doing. It's also going to check celiac, everything else too. Yeah.
Probably somebody
You guys know that
for some things.
Okay.
I just put them on probiotic, Saccharomyces boulardii, because that quick in surgical practice, I do all the time because they're on antibiotics and it reduces.
What do you put on?
Saccharomyces boulardii, it neutralizes the C. difficile toxin. You know, when you get that C. difficile toxin, and it also increases the appearance of the bacteria to the colon. So we put 10 million per day, like before surgery.
Really helpful.
Yeah, my son's been on here. It's really, it's the second research robotic, except when it gets out through. So it's really Flora Store, have you ever heard of that? It's the brand, you can get it brand over there. That's Flora is very good.
Yeah, well, that's what we check in our stool too.
Yeah, but it controls that. It controls the unit out. What probiotics company?
I use a lot of I use several different ones, depending on what I'm looking to do, but they've got one with 4 or 5 different strains. One is 100 billion, so you do 1 a day for a month and then twice a week. And then there's one that has prebiotics and sprouts in that. And they have various different forms, but I like those probiotics. This one has been really good. As it responds well. I use about 6 small urine encapsulations.
Urine encapsulations?
Somebody told me I was better than easy listening.
How come?
I So those would be the actual I have to find out more about the where he gets his metabolic
We've been using a new one called Essential 5 One, and that is great. It's got protein, it's got copper, proteins, and it's got really almost corrects every deficiency that we find that they have. Yeah, and it's just a multivitamin. If you compare it next to other multivitamins, it's got everything. Which company is it? MP Prescriptive. Look at it because, you know, it used to be that we put everybody on so many different things, and now the 5-in-1 is amazing. It's care of everything. And they come so nicely, you know,
But do you like the possibly we're just talking about?
The 5-in-1's new though.
What's the 5?
It's
That's all the
prescriptive.
B12 and all that.
It's called it's a multivitamin.
Oh.
But
Liquid vitamin?
4 capsules. It's kind of a bummer. Yeah, but I mean, it really does have everything in it. And now it's like putting in, you know, and it's nice when you can find your protein, zinc, and copper. You know, really everything in there. So, I don't know. But all I know is that they're working on our Spectracell. Everybody's coming up nicely. So, yeah.
Or you know a lot of
yeah, I only use chelated. I use it because when a lot of people on this program inhibitors, glycinate now because they have a vascular problem like prednisone, that has a better benefit. So it kind of almost customized with chelated too, depending on the medical problems.
what would you do for someone that's just had PSR forced in, so you just where would you
Defibrillation for atrial fibrillation.
the top of doing it?
So he's getting paid for atrial flutter and just buy it. I would just put about 1,000 milligrams of these magnesium. So kind of magnesium, because that helps control rhythm. It also helps control and I would also, he said stints, I would make sure it's homocysteine control, because if you keep homocysteine low in the instance they reapprove stints by 40%. You have to look at stints. I don't have blood vessel like a SNU vessel that's going to develop me. And the other thing I would recommend, he hasn't had vitamins. Then I would put him on protein. I would definitely put him on that because their study shows that it reduces the hyperplasia of the vein. Yeah. Some people, they're almost everybody I have even close to
I'm not really working there right now.
surgery just like they do. Started magnesium program for people with CRPS.
My body's not used to it.
We have magnesium. Yeah, it was based on another study, and they did better with 3 to 6 months. Girl we put it on, her RSD and her legs all sweat for about 4 months.
Wow, what was the dose of the isolate?
70 milligrams per kilogram. We do like a 4-hour monitoring. But we haven't had any trouble. I mean, then we reduce the mag, and it goes up to like 3.2 at the time. I think we've done about 1,000 people, and most of them, one of them was, I see a lot of one of them had it in the left foot, and then she sprained the right foot, so I put it on up and then I put it on that early. And then easy on natural NMD or something. Ketamine, you know what ketamine is? Ketamine is an NMD receptor. But everybody wants to have hallucinogenic anesthetic. I mean, I went to Florida and saw this. It's kind of like ketamine so I went down there and watched this protocol, and he puts it like 1160 to overnight, I used to put on magnesium, and I would give ketamine infusion. Although, so it reactivates every time you do an incision, so like that. There's other helps reduce the inflammatory cytokines that produce hormones. That's how it works. Got a lot of work to that's an enormous clinic, but that's my personal really difficult. We put the neurostimulator that works, but I had one girl, very good, 18 months, result coming off, and just her whole body, and we put a neural stimulator in her spine for her arms and legs, but maybe I was instead, it keeps flaring up through the stimulator, like she never had to go on great thing was she graduated from college and her dad was vice president of so that was an experience. There ain't much detail. It's like it's not an FDA-approved thing.
So she's still on it?
No, she said I think what happened is I reset her immune system with TH1 and TH2 immune regulation. But Dr. Watkins does really good work with that RC and she found that when you give her a high, it increases the inflammatory side of the production. So that would when she gets it's across the inflammatory side. I did an initial one about 4 years ago for 10 patients and they had great results. You know, like Now they're doing about 30 studies last year.
So this program is
So it's a complicated thing. I think it's a immune stimulated, let's say metabolic process. It's so complicated. I met the scientist who's she's like scientist for the Monash seed syndrome Foundation. She was doing like so I asked her, I said, don't you think it's metabolic problem? She said, yeah, because if you get this brain, there's a lot of green. She's a lab. She's a
and speak to them. I would love to do something like that.
These are asking what
the patient needs to list out a couple of things like.
You should look at that.
And it would be fun.
Amazing. It's good for kids.
It's good for every, really any inflammatory disorder. That's easier for the liver, problems.
Yeah, I told her. I said,
But I'm not sure. I don't know that helped her so much. Now she's on. They're using it in Germany.
She gets farther along.
No. So if you go to the website, research it's a woman from the United Kingdom. She has that website. My lecture that I gave in Las Vegas, you know what the American Academy of Intelligence there's 3 years ago. But if you go to the MP3 section, that's the lecture I gave. And then they interviewed me on YouTube. But that was just but that's a good sign because it gives a lot of different cases. When you use it, the response has been, the guy